Start. I can start. Okay. And some of the molecules available in South Korea, Japan, and currently in some other countries, including China. So, this molecule has a good number of publications. Few are available in English language. Many are available in Japanese language, Korean language, as well as Chinese languages. So I will try to cover about the details of the molecule, how it actually can be positioned in the management of respiratory allergies, very specifically allergic rhinitis, what are the mechanism of actions, and what are the doses, how this molecule has to be used. So with this, if I proceed to the very first basic slides, I'm sure that all of you who are present here are aware of the approach towards the allergic rhinitis in terms of the diagnosis to the management, in terms of the treatment. So we definitely take the history of the patient, which is extremely crucial. Look at the signs and symptoms, the duration of these illnesses, and based on that, we categorize the patient, the mild to moderate to severe, and also strategize our therapy approach. So all of you know that there will be watery diarrhea, sneezing, itching of the nose, and then you look for the diagnostic tests like skin prick test or sometimes the intradermal test if something is related to the dermatological condition or often there are rules of the patch test or allergy provocation test. So this is very nicely elaborated in the Indian guideline as well, which was published in 2023 by Dr. R. Kumar and the group, which is called Indian Guideline for the Diagnosis of the Respiratory Allergy by ICAAI and NCRAI and South Asian Association of the Allergy, Asthma and Clinical Immunology. So they also covered this, the whole treatment gamut of the allergic rhinitis and the respiratory allergy. So we generally try to use these molecules, which are listed on the right hand side of the screen, starting from, of course, the allergy control, which are very important but very difficult to practice in the real world. Then comes the pharmacotherapy, where the antihistamines, the decongestants, steroids, nasal, and also inhalation, in combinations. Then comes the leukotriene antagonist, and then finally, if the fast line does not work or in combination does not work, in moderate to severe type of the patients, we generally go for the immunotherapy as well. So here comes the role of histoglobulin when the patients are tried and tested and with the, of course, the acute conditions managed by the antihistamines, second generations or in combination with the intranasal steroids. And still the patients are not controlled, the symptoms are not controlled with the medications. So definitely the aromatherapy can be started and then gradually the number of pills, number of molecules which are used to treat the patient can be tapered. So now if we look at the what should be the ideal, the anti-allergy therapeutic options, whether it is in a single molecule or in combination, it ideally should be non-allergen specific. Why? Because it is very difficult. All of us know, to pinpoint a specific allergens is very difficult. There are many times there are overlappings, there are multiple allergens which are also triggering the conditions. It should also comprehensive in blocking the allergy cascade. So naturally, that's why we target the histamine, blocking the receptor blockage. by the antihistamine. The final end pathway where the histamine is anyway getting released, but it should not manifest the symptoms, and therefore we actually try to block the receptors. Also, ease of administrations, like if too frequently the drug is to be given and for longer durations, that will actually affect the quality of life as well for the patient. Of course, side effects also come into play. So, if it is easy to administer, maybe a one single dose subcutaneous or a oral pill can be considered. Short duration of the treatment course, which can be another ideal way to think about. Then comes the reduced medication burden. No patient would like to have 4 or 5 medicines every day. There are chances of the compliance issues as well, missing pills as well. And of course, it will increase the quality of life of the patient. The patient will not have sedative effects, or if somebody has profession where the driving is important, alertness is important, or the attention is important. So any other drugs can actually affect their quality of life. Also, the source are nice. Of course, well tolerated, safe, and cost effective. So with this, I try to now brief upon the histoglobulin. So what is histoglobulin? Histoglobulin is a normal human immunoglobulin, uh, as mentioned in the Indian pharmacopoeia, present at 12 milligram of dose, and histoglobulin chloride, uh, 0.15 microgram, and yeah. So it is an immunotherapy option for treating the allergic disease. So it is coupled together strictly in a defined proportion, and it has capability of eliciting an immunological response. In the next slide, I will try to explain how. And it is to be used in recurrent conditions, chronic conditions, except the acute attack. So when the patient is having any acute attack, definitely the other medications which are the standard therapy, steroids, antihistamines, and everything has to be tried. When the acute attack is gone, but the patient has entered in a chronic phase or recurrent phase, and or non resolution of the conditions, then this molecule can be thought of and can be added in the prescriptions. So how it works? So all of us know for any allergic conditions we need a sensitization phase followed by the effective phase. In the sensitization phase, the person is exposed to the allergen, the immune system is get exposure of the allergen, and then the body develops the memory cells, body is sensitized, ER cells will finally help the B cells to produce adequate amount of the antibodies. These antibodies are there. Also, the T cells actually remembers that particular allergen. So next time when there will be the allergen exposure once again, so there will be the cascade pathway activated. There will be release of interleukins. There will be release of the cytokines, and that will either release the histamines and the other mediators from the mast cell, or it will trigger the cascade pathway finally that will stimulate the eosinophil, and there will be release again the final effector like the histamine. So how histoglobulin works here in the entire mechanism? Histoglobulin works as a histaminopexic effect. So it increases the serum histamine binding capacity. I will come to the next slide about little bit about it, what is serum histamine binding capacity. So the other process, like it eliminates the histamine release from the mast cell and the basophils. So how? By blocking different interleukins and also blocking the receptor through the antibodies which is against the histamine after the injections which are given. And so then there will be less of histamine available, free histamine available to bind to the receptor and cause the effect like all the allergic symptoms. Then comes the alter, how it alters the cytokine production from the kidney helper cell by possibly inhibition of the interleukin 4 and the reduction of this immunoglobulin E, what we generally see through the after the post-histoglobulin administration is by this mechanism. And it also binds with the interleukin 5 production, and that actually helps in the inhibition of the eosinophil accumulation. So if there are less of the eosinophil accumulation, so there is less release of the final effector mediators, and naturally there will be less of the symptoms as well. So, if I summarize then, so when the histoglobulin is administered, it produces the antibodies against the histamine. So it blocks the effect of the histamine by blocking the histamine binding with the histamine. It also enhances the serum histamine binding capacity, and serum histamine binding capacity is found to be a very important factor in the allergic patients. They have so allergic patients have a low histamine binding capacity. So there are a few evidences to that as well. Now coming to the serum histamine binding capacity, so there was a path-breaking work which was done very long back by Dr. Sivanandan and group from Coimbatore. So what they found is that the allergic patients has a low serum histamine binding capacity unlike the normal people. Normal individual has a higher level of serum histamine binding capacity. So there are going to be histamine antibodies in the serum, and these serum the antibodies actually binds in a challenging conditions and limits the effect of the histamine in normal day-to-day scenario, because we are getting exposed to various types of allergies, every allergens every day during our day-to-day life. But not everybody is manifesting in the allergic conditions. One of the reasons is that you have a healthy level of the serum antibodies against the histamine, which is called the serum histamine binding capacity. But for allergic patients, it is low. So what histoglobulin does, that it increases the low histamine binding capacity to a higher level, so that the same person who was earlier allergic to certain allergens have now higher histamine binding capacities, will now have a better tolerance to the allergens and less manifestations due to the histamine release in any given challenge condition. So this is one of the study where he did, and he had more than 135 patients he had. He first prepared the patient by use of the antihistaminic drugs like cetirizine, levocetirizine, neutralizing all the other conditions, use some of the loratadine, and these patients have received all kind of combinations of this drug. Then he has used histoglobulin in phase 1, 6 primary dose weekly, and followed by the 3 booster dose on 15 days, 1 month, and 2 months. And later he checked that what is the serum histamine binding capacity as well as the IgE level. So what he found, you can appreciate here, those patients were receiving all these antihistaminics in combination, the 4 drugs which are differently used on these patients. They had a serum histamine binding capacity at a average range of 83. And post, the histoglobulin therapy, so their 83 has increased to 111.6 microgram, and that has raised the level in more than 90% that has actually increased in 90% of the population. Out of total 135 patients, in 122 patients, this has increased because of the use of the histoglobulin with a 6 dose plus 3 dose. And overall, 98% of the patients who are allergic to the defined allergies, they were using some sort of anti-allergies, they responded well and were free from the allergic manifestation throughout the follow-up period of the next 5 years. So this was actually one of the very investigating work done by Dr. Sivananda, where he found that the allergic patient had a low serum histamine binding level, and post histoglobulin therapy, the SHBC, which is the serum histamine binding capacity, increased to a significant level, in majority of the patients, and symptomatically also these patients were doing very well, even during the follow-up as well. Now, if I tell that what are the indications, the approved indication for booster dose is recommended in these allergic conditions like for the respiratory system allergy, rhinitis, hay fever, bronchial asthma, asthmatic bronchitis, chronic bronchitis, like spasmodic tracheitis, and there are a few other dermatological conditions like eczema, urticaria, general skin allergies, some other non-dermatological or respiratory conditions like migraine, some of the premenstrual syndromes, and other conditions. So, what is the dose for histoglobulin? The dose for the adult is 1 ml at an interval of 4 days subcutaneously. And for the children, 1 ml will remain same, but the duration, the interval will be 8 days, again subcutaneous. I'll just very quickly glance to the histoglobulin studies in the respiratory allergy. This is one of the study from Japan where 120 patients having nasal allergy, they were included in the study. Later, 26 dropped out because for this kind of office treatment, there are high possibility of the patient drop out. Once they are all right, symptom relief, they never turn up to the clinic. They will again come back maybe after a year or 2 years or so. Anyway, so if you just look at the significant level of patient having the resolution of the conditions, which is effective rate, excluding rather effective, which is around 50% compared to 70% in the placebo. And this rate, effective rate in the histoglobulin group was superior to the rates in the placebo group, and there was a statistically significant difference. And side effects were also not observed in any case. So there are two more study. One study again from Japan, the second one where they have used the three viral treatment and compared that with the one viral treatment, and they found that three viral treatment was significantly superior over the one viral treatment in global judgment and the improvement of the symptoms again in the allergy, the respiratory allergy. The second third study, which is the clinical study on the histoglobulin, the seasonal nasal allergy, where they also found, like out of the 30 patients they tried out, it found to be very effective in the two groups where they used three vial they used three vial per week, two vials over this three vial per week. So they found the second group was the higher than the first group. Now, another study from GSMB Medical College, UP, Kanpur, where they evaluated some 50 patients aged between 16 to 50 years with allergic rhinitis in the ENT department, and they used subcutaneous injections. 1 ml for injection at an interval of 4 doses, which is the dose as per the prescribing information in the first month, followed by the 4 injection at an interval of 4 days for the next month, followed by 1 injection per month for 3 consecutive months as a booster dose, and then one after 6 months, which was given. So what is found, histoglobulin injection is safe, effective treatment in the allergic rhinitis with no adverse effect, and it gives some sort of the positive result comparable considered for the time and the quality of life of the patients. So complete response was more than almost 50%, and partial response was observed in the rest of the patient population. So there were some dropout level again for 6 patients were dropped out. So what overall 88% of the response to the histoglobulin. So another study from Bangalore, they are also they concluded like the histoglobulin is also very effective in terms of reduction of the total eosinophil count, also the IgE level, but more so the quality of the life and tolerance to the drug is also very good. The study, again, another study from Otology and from southern part of India, where they evaluated, like, the immunoglobulin E level post histamine application, and they found, like, the patient had a significant reduction of the IgE level, which is 90% of the population. They had a significant reduction of the IgE followed by the histoglobulin administration. So what are the doses schedule? If I just yes. So last those slides, I'm just finishing. So I have two more slides just to tell you about the dosing schedule. So all these steps, all of you know that we starting from the initial improvement, then we go for the medication reduction, medication free, symptom free, and the remissions. So this is from the Korean study. So what they suggested, like, you can have these three different scenarios. Like, you can observe the initial improvement after two injections. So, but you continue the third dose. Then, if you see that if the patient is showing some sort of sign of improvement, you can start thinking about the medication reductions. Then, after the sixth injection, you can think about the medication free period if the patient is absolutely symptom free, and then you think about the booster dose and evaluate the patient after 4 weeks. And if there is no symptoms, you can call the patient is actually controlled in the from the disease standard. Similarly, the extreme condition where you do not see any kind of symptom improvement after six injections, continue the therapy for nine injections, three, and then look for the changes. If there is a medication symptomatic improvement is there, you can think about downgrading the medications. Then you can make the patient medication free, and then observe the patient again after 4 weeks and think about the booster dose, and then look for have the follow up of the patient. If the patient is doing well, there is no requirement of the drug to be administered anymore. So the recommendation is, like, that you can try with at least three injections to look for any kind of symptomatic improvement, and then strategize how you can think about another three injections or more injections to be required, or straight away go for the booster dose. So with this, I end my talk. If there is any question, I would love to take it. Thank you.
Hello.
Yeah, yeah.
Hello. Hello, friends, colleagues, and my dear students.
Yeah, you are audible. Please go ahead.
Yeah. Today, this is a small gesture from BJ Medical College, ENT Department of Ahmedabad, to help our students of January 2025 who are going to appear for their MS practical exams. And it has been noticed that many times when we were students, we used to wonder what is going to happen in the practical exam, which is the life-changing thing for ourselves, for our career. So we thought that why don't we create some mock exam, and long case being the major decision factor, we thought of doing a long case of otology pathology, that is the ear case. And today's case presentation will be done by Dr. Dhara Ratwa, and this is done on a Zoom live streaming as well as on YouTube. And on the Zoom, we will have two external faculties will be logging into. One is Dr. Renuka Bradu. She is a professor and head at LT Medical College, Sai in Mumbai. She is having more than 3 decades of academic experience. She is an author of a book on endoscopic sinus surgery too. And another faculty will be logging into Zoom will be Dr. Ranjan Iyer. Yes. He is a professor and a head at Medical College, Baroda. He is a very good administrator, very good teacher, having a teaching experience of more than 25 years. Third external faculty who is sitting right beside us is Dr. Nipa Dalal. She is professor and head at NHL Medical College, which is a municipal medical college in Ahmedabad. And over and above, we have in-house faculties of my own department, myself, Dr. Veena Prajapati, Dr. Deva Gupta, and Dr. Kalpesh Patel. We all are professors in our department, and all of us are having more than 2 decades of teaching experience. This endeavor is to help our postgraduate students, not only my students, we have students of almost all medical colleges of Ahmedabad and Gandhinagar sitting over here. You all are welcome here. We all are here to learn. And the live streaming is for those students who cannot make it. So to help and benefit all the students at large at a globe level. Now we'll start with the presentation. Dr. Dhara will start.
Good afternoon, respected teacher. I am presenting a case of a 30-year-old male Hindu married named Ankur Yadav residing at Odar, Ahmedabad, working as a vegetable vendor, presented to an ENT OPD with a complaint of left ear discharge for 5 years and left side facial asymmetry for 10 days. On origin, duration and progress, patient was relatively asymptomatic 5 years back. Then he developed the complaint of left ear discharge for 5 years, which was scanty in amount, yellow in color, foul smelling, purulent, continuous, blood stain, and intermittently relieved on topical and oral medication, and no history of eardrops coming into the throat. And there is no history of associated hearing loss. Patient had a complaint of left ear facial asymmetry for 10 days, which was gradual in onset and progressive in nature, not associated with history of trauma. It is also not associated with ringing sensation in ear, not associated with earache, headache, fever, vomiting and giddiness, and not associated with the complaint of nasal discharge, nasal obstruction and complaint of throat pain.
Now the patient had facial asymmetry. So, did the patient take any medication from anything? Did you mention about that?
Yes, ma'am. On discharge, I have medication that intermittently relieves discharge and topical and oral medication.
Alright, and then the patient has come to see you for further treatment. Alright, now what do you think can be what are the causes of the facial paralysis associated with the ear disease?
It is due to one of the complication of the chronic otitis media active.
So would you like to add to the facial nerve paralysis that it is sudden or not? Was it sudden? Did you mention about that?
Yes, ma'am. It is not sudden, it's gradual.
So what do you mean by gradual? Like it is since 10 days? Gradual in the sense, was it grade 1, grade 2 like that, or was he having initial difficulty in closing the mouth, the tent?
Initially he was having a dryness in the eyes and food retention in the gingival circus. Then patient noticed the deviation of the angle mouth.
So it was since 2 to 3 days gradually he developed the facial nerve paralysis. Alright, so that is important. Okay, proceed.
And on past history, patient has a no history of tuberculosis, diabetic mellitus, hypertension and asthma. And there is no associated history of any surgical procedure previously done or any prolonged hospital admission. Personal history, patient has a mixed diet with an...
Can you hear me?
Yes, ma'am. Hello?
So I missed you in the between because the net was not good. Did you mention type of discharge? What kind of discharge it was?
Yes, ma'am. I mentioned the type of discharge, like it was scanty in amount. Yellow. Left ear discharge for 5 years, which was scanty in amount, yellow in color, foul smelling, purulent, continuous, blood stain, and intermittently relieved on topical and oral medication.
Okay, thank you.
What are the
Carry on.
causes of bloodstream discharge?
Would be due to the cholesterol, it would be due to the malignancy, and we would be
Cholesteatoma means bloodstream discharge. What is cholesteatoma? Can you define?
Cholesteatoma is defined as a 3D structural sac lined by the stratified epithelium containing the keratin arteries that lines the middle ear cleft and causes the locally erosion of the bone.
So it is always not cyclic, it is the stratified squamous lining epithelium in the middle ear cleft, which is not self-cleansing. It may be infiltrative variety also. Alright?
Yes, sir.
And go a bit slow, you are very fast.
Yes, sir.
And why it erodes is, it's the squamous epithelium. The squamous epithelium has got a property of eroding. That is why even when there is a cancer happens, once there is a metaplasia and then a squamous carcinoma happens, right? So the squamous epithelium has got a capacity. Why every time a metaplasia to the squamous epithelium happens is, it has got it is more robust. It can withstand all kinds of inflammation and neoplastic factors, and that's why first it gets converted into it. And the other side of the coin of a squamous epithelium is, it has got it like a crab, it erodes the bone, it eats up the bone, and that is why in a cholesteatoma it erodes the bone, right? Yeah.
You mentioned patient didn't have diabetes, right? What is the age of the patient? 30 years. How do you link diabetes with any ear disease and facial palsy?
Diabetic neuropathy, microangiopathy.
Microangiopathy, diabetic neuropathy, any other common cause?
Second,
When you see otorrhea, diabetes and bloodstream discharge with facial palsy.
What condition?
But
What
yes,
condition?
is the hand that we answer.
But patient is young, usually malignant otitis external we say okay. What is the causative organism for malignant otitis external?
You also past history of tuberculosis, right? What is the specific reason for asking the past history of tuberculosis?
because patient may present with a chronic ear discharge with facial weakness.
Matlab, what comes in your mind that you ask for past history of tuberculosis? What are the characteristic features of tuberculosis that patients may have in the past and right now presents with ear discharge and facial palsy?
Patient has a complaint of chronic ear discharge which does not get relieved on your medication. With
How do you
immunocompromised
describe tuberculosis otitis media?
Yeah. What are the cardinal features of tuberculosis media?
pained middle ear mucosa and granulation around the margin.
What about discharge? What kind of discharge the
It is
patient is?
continuous discharge. Intermittently it was, but it is continuous discharge, doesn't respond usually to our routine antibiotics.
Go ahead. You explain that it is scanty and the discharge was relieved with medication. So what do you think?
You said it is
History.
continuous, but it is intermittently relieved with the medication.
So how do you explain both? What fits into the, which pathology fits into the history according to it? Scanty,
Yeah.
continuous and relieved with medication. How to
If
explain?
it is related with medication, it cannot be continuous then.
That is what I want. Okay. Proceed.
Personal history of the patient. Patient has a mixed diet with adequate appetite, with normal bowel and bladder habits, with no history of any addiction. And there is no significant family history present in this patient. General examination. Patient is conscious, cooperative and oriented to time, place and person, fairly built and fairly nourished. No evidence of pallor, icterus, cyanosis, polionychia, lymphadenopathy or edema.
What is the vital signs, you said?
Patient is afebrile with blood pressure measuring 120/80 in the right radial artery in supine position, and pulse is 100 pulse per minute in right radial artery in supine position.
What is the importance of pulse in this patient? Is there any relevance with the pulse with this patient, or it's just to complete the examination? Is there anything where the pulse gets high or pulse gets low, or always remains normal?
Especially when your patient is having facial palsy.
Chinese media with the facial analysis. Is the patient answer?
Does anything comes in your mind?
Yeah.
If madam any intracranial complication is there, brain abscess or something, then bradycardia will be happen in the patient.
And the temperature will be
Right.
subnormal.
Subnormal. Yes, ma'am.
Brain abscess, bradycardia with a subnormal temperature. And if it is meningitis,
High grade fever.
high grade. Right?
Secondly, I would also like to point that in history, origin, duration, progress, you said the patient was having facial paralysis. Am I right? Paralysis. Patient cannot say like that. You get me? Patient will say that he noticed that there was difficulty in closing the eyes. He had dribbling of the, after few days, he had dribbling of the saliva from the angle of thumb. So don't mention facial palsy in origin, duration and progress.
You said that your patient is conscious, well-oriented, time, place, and persons. Okay. Many times in emergency, patient comes with the ear disease, and those are not oriented well. They are confused a little bit. So, what should be the differential diagnosis come in your mind?
If a patient present in an emergency with altered sensorium, then the first thing which comes into mind would be that there will be an abscess or intracranial complication that leads to the altered sensorium.
One is the complication. Which complication? You said abscess, brain abscess. Usually
Meningitis.
are the patient is disoriented with, it's a slow growing kind of a space occupying lesions where it does not give rise to high grade fever, it does not give rise to even altered sensorium. It takes a longer time. But are there any complications where patients get disoriented and they come to your emergency with a disoriented sensorium? Which complication? You have to be very specific on which exam.
Intradural abscess.
Which complication leads to disorientation in case of CSY?
Meningitis. First thing should come in your mind should be meningitis. Right? Why in a patient of a meningitis there should be disorientation or altered sensorium? Why should that happen? Whereas in the brain abscess, it is a slow growing, it doesn't happen. But it is the whole meningitis has a covering of the whole nervous system, and it irritates at the same time. So the amount of inflammation which is going to happen will be manifold compared to that localized brain abscess or something, where the irritation will be very less, and the brain will compensate for it. So you will have a kind of a space occupying lesion, slowly growing space occupying lesion kind of a symptoms rather than a disorientation. Whereas in meningitis, patient will be having a high grade fever and a disoriented. So that is very important for you. Yeah.
Even your patient who has acute segment sinus thrombosis, anytime it presents with this disorientations, right? Because it reduces the brain return, venous return, right? So there is a edema into the cranial cavity, and it may produces the confusion or disorientation.
Local examination. I have examined the patient with his consent. Patient has a complaint over the left ear, so I will examine the left ear first. Left pinna, preauricular region and postauricular region is normal. External auditory canal visualized is normal. Then I would like to proceed for otoscopy. There is a presence of discharge after dry mopping. There is evidence of posterior superior quadrant retraction with white flakes suggestive of
You
cholesteatoma.
visualize external auditory canal with which equipment?
Ear speculum.
Only ear
Ear
speculum is
speculum
sunlight.
and light. Bull's lamp and
Whose lamp and head mirror.
head.
Which kind of speculum you use?
It could be Hartman, it could be Sia.
For examination,
For
what do you
For examination, what do you use?
Examination, most common spectrum use is
Hartman.
Hartmann's.
Posterior superior quadrant, there is a presence of retraction with white plaque suggestive of cholesteatoma, with grade 3 retraction in rest of the pars tensa and grade 1 retraction in pars specifica.
Grade, okay.
What is the name of that
Classification.
classification?
Pars
Pars
tensa.
tensa.
It is series classification.
What is it? 1, 2, 3.
In grade 1, there is a minimal retraction with distortion of the cone of head. And in grade 2, there is retraction touching the long process of the incus. And in grade 3, the tympanic membrane touches the promontory but moves on cingulation of valsalva. In grade 4, the tympanic membrane touches the promontory but does not move on cingulation of valsalva.
So
And
in your case, is it moving with, you have, you saw the movement with
Yes, ma'am.
cingulation?
it's not
It's a normal mobile or hypermobile?
normal.
No, you said grade 3, no? So grade 3 is what? Atelectasis. Atelectasis is always hypermobile. It's not normally mobile. On cingulation or valsalva. Right? And what is grade 5 is there?
Perforation.
If there is a such a blockage, how will you define whether it is moving with whether it is grade 3 or grade 4? Is there any way to differentiate whether it is grade 3 or grade 4 with the ET block? The most common cause for a cholesteatoma is in the stretch-and-tube blockage, right? This is the full-fledged developed cholesteatoma. So with the ET block, how will you differentiate it is grade 3 or grade 4? Like Seagull, what do you want to say, Sade wants to say by grade 3 and grade 4? Grade 3 is, it is retracted up to the promontory, but there is some amount of air. When it is forceful enforcement of the air inside the middle ear, it comes flatter, right? Whereas in grade 4, it doesn't. What does that signify? What does that signify? What is the clinical implication of this? This is just a classification. So there are some adhesions between the promontory and the tympanic membrane. That is grade 4. But all these things we do with the valsalva. But if the valsalva is negative, the stretch tube is not functional, then is there any way to say that this is grade 3 and grade 4? Huh? Legalization is you are forcing the air from outside. So if it is grade 4 or grade 3, it's already medialized. When you talk about movement, it has to force from inside, not from outside. Sigillization is for knowing whether the tympanic membrane is compliant or is malleable. Tympanometry. So there is no clinical way of differentiating grade 3 and grade 4 if valsalva is negative. You get it?
Examining the right ear, a pinna preauricular and postauricular region is normal. Visualize external auditory canal is normal. And the tympanic membrane pars tensa and pars placida is normal. Valsalva and cingulation on the right side.
You told it's a retraction pocket with the cholesteatoma. Which kind of retraction pocket develops into cholesteatoma purpose? Not all retraction pockets develop into the cholesteatoma purpose.
Deep pockets which does not have self-cleaning.
Okay. So is there any demarcation between shallow and deep pockets in PSQ?
Hello?
Is there any demarcation between shallow and deep? How can you say this is shallow pocket or this is deep pocket? That's what I meant to ask.
Keratin fibrils does not get.
I think he is talking about the fundus, isn't it? So I visualize.
If you can visualize the fundus or the bottom, it is shallow. It is usually self-cleansing.
And then
Not that it is a deep which may lead to cholesteatoma collapse.
You can say it is a pocket only when you see the fundus. Otherwise, just say retractions, right?
And a very common question is why it is common in PSQ. Actually, it is common in attic, in pars flaccida. But if you can compare with the pars flaccida tensa, it is common in PSQ. So why it is common in PSQ? First, why it is common in pars flaccida? That is the commonest. Sex space is the commonest place, right?
It's more common in pars flaccida due to the disorganized arrangement of the laminar propria of the tympanic membrane.
Middle layer.
Middle layer. Second, it is not attached to the tympanic sulcus. It's absence of the tympanic sulcus.
Doesn't give to rigidity of the trunk. Yes. And why it is common in PSQ in pars tensa?
In posterior PSQ region, it is due to the sparsely presence of the middle layer of the tympanic membrane. The second is the shallow tympanic sulcus that does not give a attachment to tympanic.
Yeah, but there are other reasons also.
How air circulation?
The pressure,
What is
air pressure thrust is more towards the posterior superior quadrant compared to the anterior quadrant of the tympanic.
So that might be the reason.
What is the role of ITA and ITP? Where does the ITP, metal isthmus tympanicus posticus is located? What is the role of cluster of mucosal folds and ossicles? What is the role of its attachment and angulation with the EAC? What is the role of air thrust? These all are reasons. According to Bernoulli's phenomena, the air thrust is more in PSQ. That's why there are more chances of getting retraction.
On tuning for test, let's say it is negative, rin is negative on 256 and 5 and 2 and positive with 1024.
With the retraction, can you visualize the ossicles? Did you mention about the ossicles? Even if you don't visualize, you have to mention.
Then 5 and 2 and positive with 1024.
With the rate.
So why it is common to examine with the 512 only? Like if you don't have all three, it's better. I mean, it's adequate to examine with 512.
Because it falls into mid speech frequency, has an optimal tone decay, and it is more heard than the felt.
And the problem with 254
It causes more vibration than the auditory.
and 1024,
It has a tone, high tone.
faster tone. Okay.
What exactly mean by tone decay? When you say more decay, it means what?
When I strike the unit fork on my elbow and bring it to the ear, the duration of vibration is lost earlier in the 1024.
Okay. So why it is more with the higher frequencies?
Anybody? Why the tone decay is more
Yes,
at the higher
yes.
frequency?
Please go ahead. You can answer.
Frequency is inversely proportional to the wavelength of the sound. It's like,
Yeah, so what happened?
so according to compression rarefaction, so more the frequency, less the compression rarefaction, so less time it will, more time it gets decayed faster.
Yeah, true.
So it is the physics. Okay, the frequency, the 512, suppose 500 frequency, it moves more faster.
Yes.
But if it is a higher frequency, then it will be a slower in amplitude. So to reach to a destination, it requires a more time. Right? So what happened? It is a condensation and rarefications. Some created by this object produces compressions, then rarefaction, compression. So more frequency. If it is a higher frequency, to reach a particular destination is required a more time. So it decays fast in time. Right?
Did you do ABC?
Yes, absolutely. It's equal on both sides. And Weber's lateralizing to the left side.
Are you comparing ABC on patients both sides or someone else? Absolute bone conduction test has to be compared with
patient and examiner.
you told it's equal on both sides means what?
The absolute bone conduction test is equal in left ear when compared to examiner.
So it is not reduced, not equal. It is not reduced or reduced.
Facial nerve examination. Patient has a left side grade 3 facial weakness present with complete closure of eye with maximal upper and slight weakness of mouth at upper and obvious asymmetry seen. Rest of the cranial nerve examination is normal. Fistula test is negative. Examining the balance test.
How you do fistula test? How you do fistula test?
I will first fix the head of the patient and then press the tragus alternately and we'll see the check for the nystagmus is present or not.
How does this tragus pressing? Yeah, only nystagmus.
A patient complain of giddiness.
Giddiness and you will see better nystagmus. What is the other method? Suppose you don't do with your finger.
Then single. What you must be knowing, right? What are false positive, false negative causes?
False positive, it is seen in the congenital syphilis and also in the staphylococcus. And then false negative, it is seen in the dead ear as well as if it is a labyrinth fistula plugged with a cholesterol. Then on balance test, negative Romberg's test, tandem walking, no evidence of any nystagmus, no evidence of dysdiadochokinesia and past pointing and finger nose test.
So you check for cerebellar signs as well. So tell us the all cerebellar signs.
Romberg's sign, then Altenberger's sign, then I have X.
When you
All
say
cerebellar signs.
you already just spoken. Which that?
What are the cerebellar signs?
Romberg's test, tandem walking, Altenberger's test, dysdiadochokinesia, fast pointing, and finger nose test.
What's about nystagmus? What's about knee jerk? What is the kind of knee jerk in cerebellar signs? Pendular knee jerk. Good. So are signs.
On examination of the nose, patient has a
You haven't examined opposite ear? Normal. Just normal. On one side, yeah. If the patient has developed cholesteatoma on the left side, how come the right side ear would be absolutely normal? So it is unilateral eustachian tube dysfunction that may have led to the retraction and then cholesteatoma.
You have to mention about the left ear also. Or the
Right ear.
Alright, so we
Opposite ear.
opposite.
Opposite is absolutely normal. The drum is absolutely normal. Explain how come unilateral eustachian tube dysfunction? Is it possible that eustachian tube without any organic pathology, like in the nasopharynx causing space occupying lesion blocking the eustachian tube on either side, the patient is having only unilateral and opposite side is absolutely normal? Is it possible?
Okay, proceed.
examination of the nose. The external skin of nose is normal. On deep breathing column, normal vestibuli and normal external nail. On anterior rhinoscopy, septum is centralized with normal nasal mucosa.
Do you examine with anti-rhinoscopy? You have done anti-rhinoscopy? Radicum speculum is to be held on right side, left side, what side?
Left side of the examiner.
Okay. Why on left side? Why not right side? Why you prefer left side? Because you are lefty or why not right side?
Where is the bull stem?
It's on the right side of the patient.
So how will you position your bull stem?
Examine the nose, I have to focus the air on the columella of the patient.
What is the distance of the bull's length from the shoulder of the patient?
6 what?
It's about 18 centimeter lateral and above the shoulder of the patient. Now the bull's lamp is convex or concave?
It's concave.
No,
Convex.
no, it is not concave or convex.
Convex. Convex. Yes.
That's why it is called bull's eye.
Yes.
Anterior rhinoscopy, septum is centralized with normal nasal mucosa. Posterior rhinoscopy is normal. Examination of paranasal sinuses is normal. Oral cavity normal, and examination of neck is normal, and no evidence of any lymphedema. And my probable diagnosis is patient has a left chronic otitis media with active
You have done posterior rhinoscopy. If you don't have mirror kept for posterior rhinoscopy, how can you comment about posterior nares?
It was there in the tray, examination tray. PRS mirror. It was there and I did it.
Yes. St. Clair Thompson's posterior
No,
rhinoscopy.
no. The name of posterior rhinoscopy mirror is not St. Clair Thompson. It is ideal mirror. The name of posterior rhinoscopy mirror is anyone from audience can answer. Those who are exam going, those who are not passed. The name of posterior rhinoscopy mirror is Mackenzie. St. Clair Thompson is ideal mirror. It's a bayonet shaped, na? Posterior rhinoscopies. If you don't have mirror, then how can you examine posterior nares?
How will you do posterior rhinoscopy? What will you tell to the patient? How will you do posterior rhinoscopy?
Procedure of how to, then I will depress the tongue of the patient with tongue depressor, and by using a Savlon, I'll pass my posterior rhinoscopy mirror behind
You are using Savlon for what?
to avoid fogging.
So you have to tell no, that you will apply Savlon on the mirror.
Mirror.
Then
What is the best method? What is the best antifogging?
Passing through the saliva.
no.
To prevent fogging, what do you use? And what is the best?
Ideally here.
It is always hot water or spirit lamp.
Spirit lamp.
Spirit lamp is ideal.
And the mirror should be heated by what surface?
Flex.
Huh? Back of the mirror, not directly on the mirror.
And the mirror surface will be facing up to the doing the posterior up and towards you. When you are doing posterior. You say that in the posterior we want to depress the tongue. Why do you want to depress the tongue? You want to look into the nasopharynx. Why do you want to depress? What happens ergonomically? What happens in the oral cavity? Ergonomically, what happens in the oral cavity when you depress the tongue versus when you protrude the tongue?
Increase the area of the oropharynx.
One is the height of the oropharynx will be more when you are doing depressing. Second thing, what will happen? What will happen to the base of the tongue?
And the soft palate that will more space.
The base of the tongue also will go down, right? And you ask the patient to breathe through the nose or through the mouth,
And that's the patient is breathing through the nose,
right?
to avoid fogging.
To avoid fogging or something. When the patient breathes through the nose, what happens? What happens?
Relaxation of the palatal muscle and
The soft palate will come down. So there will be more space into the nasopharynx, right? Okay. And then when you ask the patient to protrude the tongue in a case of IDS, what happens? To the ergonomics of the tongue, to the larynx, to the pharynx, to the soft palate. Which space? Because when you are depressing, you are increasing the height. By protruding, you will decrease the height of the oral isthmus, right? So still you want to make the patient protrude the tongue.
But the base of tongue would be much anterior.
Yeah.
Space.
So when you are protruding the tongue and depressing the tongue, the larynx will move upward and forward. So you will get more antero-posterior diameter, and the tongue also will come anteriorly. So the antero-posterior space you will get will be more. The epiglottis will be tilted little anteriorly, so you will be able to peep into inside the larynx. So if you want to see the vocal cords and all, this is the ideal condition, right?
So what is your diagnosis? Complete your diagnosis.
The probable diagnosis: patient has a left chronic otitis media with active spinozal disease, with moderate conductive hearing loss, with left side lower motor grade 3 facial weakness, with no intracranial complication.
How will you proceed
With
now?
no nasal or oral open infection.
So what could be the reason? Suppose septum is centrally placed, no turbinate hyperopic, nothing. There is no obstruction in the nose. So what could be the reason of unilateral cholesteatoma?
Patient may have some upper respiratory tract infection that impairs the mucociliary function of the middle ear. That leads to negative pressure in the middle ear and causes detraction pocket, which does not get
Let's
resolved.
see, otitis is 5 years, right? It is for the 5 years. So it is very long duration. So there has to be some obstruction in the nose or in the Eustachian tube. When it is not properly functioning, then only.
Anybody?
So the basic pathology lies in Eustachian tube. But nose is absolutely normal. There is no septal deviation, no obstruction in the nose. So what could be the reason for Eustachian tube dysfunction? That I am asking. And it is unilateral. Other ear is absolutely normal.
Yeah,
Right? So what could be the reason?
unilateral. If it is a bilateral eustachian tube blockage, then opposite ear must have some grade of retraction. You said it is absolutely normal.
Then the patient is pretty old, and the history is.
The patient is only 30 years.
Yeah.
History is since 5
For
years.
30 years, patient
So
was
what could
fine.
be the reason?
And just for 5 years, patient's ear has gone for a toss. So what can be the reason?
From what
What must have
yes. Other students?
If we are suspecting that the only one side of the ear is involved, and we suspect that ET is not involved, then there is selective attic disventilation on where only posterior isthmus get blocked. So only attic disventilation.
But why?
But
there
why?
is selective
What could be the reason?
ventilation? Why would it happen?
Why that should be selective?
What will be the precursor
The ventilation
to make that atelectasis happen?
No, but only one side, why it should be affected? If
Even
everything
if you don't
channel is right,
maybe what is the reason for that thing to happen? That the only a smaller bronchitis period. What can be the reason behind it?
as simple as that, unilateral eustachian tube blockage, that's it. Why and what?
So what are the causes?
What are the types
That
of
I'm asking
hysterectomy
for
blockages?
unilateral, yes.
What are the mechanisms of ET blockages? Is it always structural blockages or anatomical blockages? Or if there is something called as eustachian tube dysfunctioning because of pectorals, because of dynamic blockages, because of the lack of mucociliary clearances. There are things like that also. No? There is a peculous eustachian tube too. But unilateral again. It can be unilateral, not necessarily. It can be. It can be. Like what must have, there are two theories behind this, why it should happen. This is a very commonly question asked, and it is a hypothesis, nothing is proved as such, right? But we can imagine that, as she said rightly, patient might have had a very bad respiratory tract infection once, where one or ET might be more vulnerable compared to the other, and that had blocked for substantial time, wherein the most vulnerable portion of the tympanic membrane, which happens to be the posterior superior quadrant, must have been withdrawn inside, and there might have been developed some adhesions or something, wherein now that retraction, that area is not getting ventilated, and that time it was debris formation, but over long-standing retraction, the clearance of the tympanic membrane, which is outer towards the periphery and outer, has been hampered, and now a vicious cycle has been set in. That is why this is a cholesterol. This is one very a theory where you can accept kind of believable theory. Second thing which might be possible, that there is a unilateral malfunctioning of the stretching tube recently developed for some reasons, and then the whole vicious circle has happened without upper respiratory. Because in past also she is not given a history that patient had the upper respiratory infection. So to me these are the two postulates for a happening of a unilateral
Eustachian tube dysfunction.
ET dysfunction.
How will you proceed now? How will you treat your patient?
First, I will go for audiological and radiological investigation for this patient. And for audiological, I would like to advise for the pure
Direct audiology, no microscopic examination.
Which is better, autoendoscopic or microscopic examination?
If the routine OPD endoscopy is convenient.
No. You have both in your hand.
Your
Auto and
endoscopic
micro.
examination,
Which
your
one is
diagnosis
better?
is, you have read the diagnosis. So now for further microscopic examination or
Is better or endoscopy?
And why? Suppose you say microscopic, why it is better?
And
Suppose you say endoscopy, why it is better?
Magnification.
which one is better for examination of ear?
Microscope is better because it gives a depth perception of the.
Is there any role of like autoendoscopy in this particular?
It gives a higher magnification towards the retraction pocket, so you can see look for the fundus and the.
Investigation or the investigation?
Like to go for radiological investigation.
Which will you do?
HRC temporal.
Okay. What will you look
Why
for?
HRCT? You have already some complication. You have already some extra cranial complication like facial palsy. Then HRCT is not the preference of CT scan. You need to go for some other kind of CT scan when you are suspecting some other complications. Already you have facial palsy, contrast and
What will you look for?
I think for the extent of the tegment plate, the dural and dural plate, and the involvement of the eustachian tube, height, raised tubular bulb. And if it is involved in the status of the cochlea and the oval window and the
vestibule, labyrinth, everything.
So this patient has got a facial palsy, right? So what do you expect in your CT scan? In this particular patient, what is your expectation?
there could be a dehiscence from bony facial canal.
It is the most common area for a dehiscence of the facial canal.
Then it's segment of the facial.
Why does that happen?
Because it has only two ossification centers, so there is more likely if there is any faulty fusion between the two fusion in the two ossification centers.
Is it? Or which reason? In other reasons? Where is the most common cholesterol sitting? Place where cholesterol is found? In the attic with the PST. So that is the most common area where the cholesterol is in contact. Is it the faulty ossification जिसकी वजह से ये हो रहा है? Is it some theory of a cholesterol which is creating bone erosion? Because bone erosion in cholesterol happens in all the places. So it is not that theory. It is a theory of cholesterol eroding the bone. Why the cholesterol erodes it?
The enzyme produced by the cholesterol that causes the bony erosion.
Which are the enzymes?
What are they?
Matrix metalloproteases 2 and 9, acid phosphatase, and
You said two, no? There are more others. Protease, Otology.
So only enzymes are responsible for yes, pressure necrosis, then avascular necrosis. Yes, that also leads to
And what are the pathways for spreading of the cholesterol?
It can spread to the posterior epicondyle, it can spread to anterior epicondyle, and third is posterior mesotemporal.
Why so?
When the cholesterol pass through the anterior pouch of voltage, it can through this it can pass through the anterior epicondyle sinus space. And in posterior epicondyle,
What density when I hold means? So,
It's comparatively less. So we'll like
that is what is going to. There is the head of the malleus sitting there, and there is the anterior epitympanic cord and the muscle which is sitting. So the anterior epitympanum is the most robust area in the whole attic, where because there is a cog also there. So there are a lot of bony things there, and there is less of a air pocket there. So the you finding a cholesteatoma is very rare. And if it is there, then we'll talk in the management. That is the most common area where you might leave behind a disease. Right? So we talk about drilling the cog and we'll talk about it. We'll talk about
Lepidopteris is spread via the posterior pouch of voltage, and it enters through the superior impudence vein, and cholesterol spread to the lateral to the attic and edicus, and it passes through the edicus and edicus. Another is through the inferior impudence space. It goes to the medial to the it spread to the sinus tympani facial recess, and to the posterior tympanic recess. Again, it goes to the epicondyle.
it's called a tympanic spread, and the one is a retrotympanic spread, and the third one is the apicus.
What is pathway of airway? How airway? Pathway of ventilation through nose into the ear.
From the eustachian tube,
Through nose to both.
the air from the nose passes from to the eustachian tube, enters into the mesotympanum, then it goes to the anterior tympanic isthmus and posterior tympanic isthmus. From the anterior tympanic isthmus, it ventilates the attic, and cruciate space is ventilated by the posterior pouch. And from there, it goes to the editors and entrum.
Then
So some of the air
Then
goes
what?
in the through the posterior tympanic fossa.
Posterior tympanic isthmus and mesotympanic.
And a posterior, yes.
does all the air get absorbed or some of it comes out? It's like this or it's like one way? You told is a one way. All the air that goes through eustachian tube gets absorbed into the middle ear or some of it comes out?
What happens?
There is a generation of the negative pressure in the nasopharynx that causes.
Some of air comes out or not? It is a circulation. It is a circulation or a one way?
It is a circulation.
Yes. If it is a one way, then imagine how much air gets stuck into the ear. It comes out also. That is a pathway complete. What are the boundaries of cruciate space you told repeatedly? What are the boundaries of cruciate space?
Superiorly, it is limited by the lateral malleolus bone, medially and inferiorly by the neck of the malleus, and laterally by the pseudomanimal pars.
Parts?
Let's
Let's see. I don't think sputum comes there, huh? Only pars placida, laterally.
What is the final treatment? You have investigated, right? Audiological, radiological, everything is done. Is there any role of medical treatment? Because patient has recently developed facial palsy. So you will go for
surgical.
surgical. Which kind of surgery?
I like to go for the modified radical mastectomy with facial nerve decompensation.
Is MRM can you define? Modified radical mastectomy.
Modified radical mastectomy is defined as elimination of the disease from the middle ear cleft, with making a common cavity for and a mastoid middle ear and the EAC, leaving behind the healthy tissue for hearing stimulation, for further hearing stimulation.
So on starting of your surgery or planning, you are sure that you are going for MRM only?
So you said per-operatively, no? What
Directly,
came into the
directly you are not pretty sure that you are going for MRM only.
Okay, if you have to support your own statement, you have to justify this, yeah, I want to go in for, I'll end up doing MRM only. I don't want to go in stable as exploratory mastectomy and then convert it. What are the points in favor of going in for MRM?
If there is
If you have a patient.
presence of disease in the facial versus sinus tympani and the
The patient has posterior superior cholesterol.
Posterior
That is the one reason.
sinus तो तुम्हें पता नहीं है कहाँ है. Posterior superior cholesterol. Second, major reason why you need to go into the MRI. Yes. One injection.
No, that is not the reason.
No, that's not the reason.
Patient has already developed
If you want to
complication.
do CAT or something, your ET has to be functioning well. So okay, that point taken. Any third reason?
reconstructible posterior
Patient
canal.
has already developed a facial palsy.
Already it is complicated case.
Patient is a already complicated case. And if you, what is the other option if not MRM? What the other option you will have? Combined approach treatment. What are the prerequisites of doing a combined approach tympanoplasty? There are certain prerequisites. ऐसा हो तो ही combined approach कर सकते हैं. One is the ET should be functioning well. Okay? Your canal, posterior canal wall has to be
Healthy.
healthy, right? If at
It
all
is
there is
posterior
erosion,
cholesterol, so might be partially eroded.
yeah, if at all there is erosion, then
there is no point of
the
keeping-
amount of erosion has to be judged on your CT scan. If it is more than 1/3 or more of a canal wall erosion, then doing a CAT will be difficult, or you might have to plan your reconstructive policies. It's not that you cannot do it. You can do anything, but then you will have to reconstruct it. So how you are going to reconstruct that also you have to keep it in mind, right? So your posterior canal wall intactness will decide whether you can do a classical CAT, or you will have to do canal wall down with the reconstructive strategies. And any other point where you will say that I'm going for MRM only, or I'll not be able to do CAT. CAT is done for a limited cholecystectomy. What do you mean by limited cholecystectomy? How limited? Yeah, anybody? इतना कहाँ कोलेस्ट्रोमा होगा तो हम कैट नहीं कर पाएंगे. Whatever, कर पाएंगे नहीं कर पाएंगे.
Rectification area very
साइनस टिम्पेना में होगा तो थोड़ा डिफिकल्ट हो जाएगा. Will be difficult, right? So this is why even if there is no complication, your CT is going to help you a lot. It will tell you how big cavity you are going to give. If it is a canal wall down you are going to do, it's going to tell you whether you can do intact canal wall or not. If you are planning for a canal wall down or intact canal wall, are you going to reconstruct the posterior canal wall by some means? If yes, then by what means? Whether those materials are available locally or you are going to procure it from somewhere. So all these plannings has to be done when you are evaluating patient, especially for a CT scan. You just don't want to see the CT scan कि इतना बड़ा cavity है, ये है वो. In addition to that, you have to plan your surgery, right? So if MRM है तो एक तो PSQ में है तो साइनस टिम्पेनी में होगा, ऑसिकुलर इरोजन होगा, facial nerve paralysis already है तो facial eroded होगा. With CAT also you can do a facial decompression. Rather nowadays it has been many years now that facial decompression means you have to keep the canal intact. In today's era, if you remove the canal and do a facial nerve decompression, that's not done thing now. You have to preserve the canal and then do a facial nerve decompression, right? So this is how you are going to present. Yeah.
But in
Again, it is, if it is a cholecystomatis facial palsy or it is a traumatic facial palsy.
yes.
Okay, if it is
traumatic,
a traumatic, then obviously you should keep the canal intact if possible.
cases of
Right,
cholesterol.
because where the ischial tube is not at fault, it is a trauma. So we want to decompress the facial now only, keeping the canal intact. But in case of erosive or this squamous metaplasia is there, then if you are a junior surgeon, then it is better to go for the canal wall down.
Yeah, that
Even the aim of the canal wall down surgery is what? Basically, you want to see each and every hidden area into the mesotympanum, epitympanum, hypotympanum, and mustards. Now, with the invent of the endoscope, right? See, we are keeping the endoscope in the nose, and you are looking at the most anterior part of the maxillary antrum. So why can you do the same thing into the nose, right? So with in the ear also. So if you keep this disease removed from the conventional way of cortical mastectomy, you can remove the disease. You are elevating them, you can remove the disease from the middle ear, hypot, and epitympanum. Now the problem is with if there is a deeper sinus tympani region, which is very difficult to keep the canal intact to remove it. So if the experienced surgeon is there and he can do the removal of the disease with the endoscope, then again you can keep the canal wall intact. So as Madam has said, so there are all the ways that you can keep the canal wall intact, but it depends how experienced we are. And whenever the complications, please do not keep the canal, right? Because in the world level, there are many experienced surgeons has performed the canal wall intact, but they always go with the MRI every 6 months for the recurrence of the remnant of the disease. And many a times, I can say 30% of the cases they have to revise. So what happened? The infiltrate cholesterol turn into the pearl. So that is very easy to remove it. But in our scenario, when the patient is not coming frequently for us, particularly in the civil hospital or district level hospital, so you will not advise every time for the recurrence MRI. So always go for the canal wall down. So at least whenever the recurrence or remnant, you can identify it.
During MRM, what are the landmarks for the facial now? What precautions you will?
Landmark for facial now identification.
On the medial column and middle ear is the process cochlear sinus. The facial nerve is above and medial, and the lateral semicircular canal
Above and middle.
above and middle.
Is it
So what is the process of cochlear
Processors as your one of the landmark facial nerve identification. Okay,
The second is lateral semicircular canal.
Yeah, okay, third.
Then the pyramidal element.
Yes.
And
Anything in the mastoid?
tympanomastoid sutural line.
Yes.
And the digestive.
digestive tree? Even when you
And
are
fossa
doing,
infudis.
yeah,
Fossa
fossa
infudis
infudis, short
that is
process of
also, that is
incus.
very important one of them.
So when, how will you know that your MRM is ideal? How much you will lower the facial nerve?
Flush to the facial nerve, vertical segment of the facial nerve, facial range.
So what is ideal cavity? Ideal cavity. There are some characteristics criteria of, so you can say it is ideal cavity.
The sloping edge, the mastoid cavity.
Superiorly approved.
Superiorly the tegment implant, posteriorly up to the sigmoid sinus, and inferiorly up to the digestive.
So you mean to these are anatomical landmarks.
So you mean to say that you will extend each and every airport to be flush with alternative MRM post-operative? Ideal cavity, ideal MRM.
कौन है ideal cavity? किसे कहते हैं कि this is ideal post-operative cavity?
Anybody?
There are some few points. Yes. What is ideal cavity?
Anyone from the other students?
Yes. Yes.
You talk about the shape, the boundaries.
Smooth self-cleansing and extra is cavity in which we can see the whole cavity with one view of endoscope, one view of otoscope.
That is post-operative, on table. That's good. Post-operative, that is ideal cavity, where you should be able to see without the speculum through the bullseye or the mirror. And without any instrumentation. It should be the posterior wall of the meatoplasty should be flush with the posterior wall of the cavity. The superior should be flush with the superior, the inferior should be flush with the inferior. It should be well epithelialized, and then it should be self-cleansing कहते हैं, लेकिन there is no severe reaction on that. So usually it is not self-cleansing, and the one of the disadvantage of a canal wall is it is a surgeon-dependent cavity. Every 6 months, 10 months, patient has to come to a surgeon to get it cleaned. So it is usually not self-cleansing. So that is the post-operative criteria for a good cavity. But you are sitting on the table and you want to know that whether what I am done is a good job or I am still yet to achieve that. So what are those things?
Smooth, shallow, well socialized without any residual disease.
Yeah, it should be round in shape. It should be sloping edges means well socialized, right? There should not be any
Residual.
There is controversy of all diseases, all air cell extension limited, but there should not be any disease left behind, right? That means you have created a good pattern, and later you have to do a good wide meatoplasty, as I said, the criteria for a meatoplasty, right? Adequate meatoplasty इसको कहते हैं, एक अंग उठा जाता है, दो अंग उठा जाता है, nothing doing. It should be flush with all the walls. When you see on the table, you should be able to see end or view of the whole cavity. That is on table, it's a good cavity. Later it's going to contract a little, so your meatoplasty is going to be a little smaller, but at the same time, even the cavity will become sad and everything will fall else in the thing on the environment. So that is the ideal cavity. What are the ways to obliterate the cavities?
How will you obliterate the cavity?
Fat, cartilage, bone. Fat कहाँ से लाओगे?
Why you want to go far when you have available nearby solution?
What do we do regularly?
Muscle.
Which muscle?
Temporalis fascia, superior based temporalis.
Fascia is muscle? You told muscle, then you are telling fascia. Temporalis muscle based on which artery?
Superior temporal.
Is it? Or middle temporal?
It's a branch of the superior temporal.
Middle temporal, that's superior.
Middle temporal is a branch of superior temporal. See, this temporalis muscle with fascia or without fascia? With fascia.
Fascia we have already taken for the grafting. Don't have fascia. We've already taken for the grafting. वही तो that's the same muscle you are going to turn. Same place से लिया हुआ है. Because the one which is accessible for taking a graft, that muscle only you are going to turn. You are not going to go up and turn back.
So it is without temporalis fascia. That is
you
one
don't
is.
have a fascia there.
So one is muscle, second is you are drilling. So what can be else? Yes, very good. Second is bone wax. Then yes, cartilages. These are the few.
Anything from lower side, inferior side, based on occipital or sometimes
Posterior.
posterior.
Posterior auricular.
Posterior. Not
What
ocular.
was the palvas flap?
Palvas flap, बोलो. Anteriorly based musculoparietal flap or of mastoid cortex.
Yes.
आपको answer.
So you can, if there's a smaller cavity, you can use that, right? When you're doing a meatoplasty and you're removing all those subcutaneous tissue and muscles, you can just rotate it inferiorly and fill it up.
Now you
So
told me
what is the
that
difference between cavity lining and cavity obliteration? There is some, terminology like cavity lining, and second is a cavity obliteration. So what is the difference between these two?
The word is self-explanatory.
Lining the cavity by what do they do now normally?
Cavity lining માટે which material is used?
We line the cavity na, every day.
Grafted.
Any kind of a
Or
fascia,
skin or-
any fascia, pericordium, temporalis fascia, right?
Even you can use epithelium also.
Yes, you can use epithelium.
Yeah.
Now you told me that there are no ossicles, so what do you think? How will you reconstruct the hearing of the patient? Or operatively, suppose
Like if you have a stapes head and no other ossicles, then what are your modalities of ossicular reconstruction?
Like to reconstruct with the cartilage,
Which cartilage?
tragus cartilage.
Brachial cartilage.
So you can use a concal also. You are already putting the incision posteriorly. You can use.
What are the advantages of a tragal? You are right. You will prefer tragal cartilage. What are the advantages of a tragal cartilage? We have been using both, right? We have seen the advantages, disadvantages of both.
For transcanal it is beneficial because there is no scarman sink or tragal cartilage. But here you are already using the postoral, so you can use the congal cartilage.
Still you will use a tragal cartilage. You will prefer tragal cartilage even when you are doing a postural. What are the advantages of the
Congal cartilage and the convex.
And it is a single. So are there any chances of pericarditis?
There are chances of pericarditis.
That you will cover it up. The thing with the congal cartilage is very robust. It's very tough. So when you want to reconstruct it with the tiny ossicles, it will be very difficult for you to mold it. Whereas in case of a tragal cartilage, it is soft and supple, so it will bend the way you want. So that is the major thing. Yeah. Okay. So even when we are doing postural, most of the time we take a tragal cartilage. Right?
If not cartilage, then what are the other modalities? Like normally you are not doing with the other things, but what options you have available when you have a stapes suprastructure?
So you can use core.
What are the material commonly used in making core? Titanium. You should be knowing. You should be knowing that two tables.
Gold.
And you can use bone also. You can remodel the bone and put on the stapes.
But in cholesteatoma case, we don't prefer to use the same bone. It is already diseased, right? So
Micro-invasion. Yeah.
yes, so remodeling and use the same bone. Okay.
Yes, it is avoided in mucous
So first you talk
epithelial.
about the autologous graft and then you will talk about the homologous graft, right? That way you will prepare your grafts. Whatever is available in autologous, whatever is available locally, that you will use. If not, then you will go for a septal cartilage or a rig or something. You have so many options there, right?
What are the advantage of using this all the port material over the stapes? You can keep a graph over the stapes in case of canal road. Why we use port material?
Space between the graft and the middle.
So you are in
Middle ear height to increase the middle
So
ear height.
what happens? How it gives an advantage?
Why do you need a same way, put in a different way, why do you need to have a middle ear space? What
Yes.
is the importance of a middle ear space? Why better? How does it help in better hearing? You having a shallow middle ear space versus you having a no middle ear space or having a normal middle ear space. Like when you do a type 2 tympanoplasties, all type 2A, B, C जो भी करते हो, you reconstruct your tympanic membrane, pneumotympanic membrane at the level of the annulus. The moment you go inside, from the annulus inside, that is a shallow middle ear space, right? So how this middle ear space कम हो जाता है तो how does it deteriorate the hearing?
Echo separation between the old and down.
बट वो तो छोटा कम मिडल स्पेस होगा तो भी नहीं होगा.
The importance of she is asking about why middle ear space has to be as pneumatized as possible.
Should be
Phase difference is different ballgame.
हमारा इम्पिडेंस मैचिंग मैकेनिज्म जो है उसमें इज देयर एनी रोल ऑफ वॉल्यूम ऑफ द मिडल ईयर, राइट? मिडल ईयर एयर का वॉल्यूम जैसे बढ़ जाता है तो क्या होता है, कम हो जाता है तो क्या होता है? As the air decreases in middle ear, the amount of vibration which will happen into the ossicle will be less. If you have a normal middle ear space, you will have a normal vibration and your hearing will be normal. The moment your air, मतलब किसी भी चीज को हिलाना है तो ज्यादा एयर होगी तो ज्यादा हिलेगा ना, सिंपल सी बात है ना? So that is why we need a normal middle ear volume of the air, right? That's why we try to create a middle ear neotympanic membrane at the level of the airways. Always we try. नहीं होता है तो it's a different thing. But we always try to create, and that is why this height of the, we say that we create a height of the ossicles. So that is what is the height. Because we are sitting down, the patient is lying, so that is the height. Actually it is going laterally. But in our perspective, it is the height of the middle, right? Okay.
And on port directly you put graft or something?
No, we will put the chip of cartilage and then
Why?
To prevent the extrusion.
To prevent the foreign body reaction, accidental extrusion. And putting cartilage on the fork is called as what? What is difference between interposition and transposition? Sometimes it is used interposition and sometimes it is transposition. What is the difference between these two?
The word is self-explanatory again. Yeah.
Sir, interposition in which we have between the two defects we have to place some material, and in transposition we have to just change the position of the skull. Some structure is attached to the main part.
Yes.
So you change the direction and you interpose, you put in between the two something. Okay. So what cartilage we are putting is in interposition. That is between the port and the port जो भी है and the tympanic, right? Why that cartilage doesn't get excluded? Most of the time when cartilage does and the port or port does. ऐसा क्यों होता है? Resorption तो फिर problem हो गया. You are expecting to resolve this from the whole body of the patient. It is autologous, so the body reaction will not be there. However, the torp and form is going to be bio-inert, but जितना भी bio-inert हो, अपनी body जितना कुछ नहीं होगा, है ना? So that is why you put a small piece of. And second thing is, this torp and form, most of them are either of a metal, gold and titanium or something, or they are plastic kind of, Teflon kind of a thing, right? So they are very sturdy. They are very rigid, I would say, not sturdy, I would say. And the neotympanic membrane which you are going to create is a very thin. So there are, and it's mobile, yeah, that is also another reason. So with every movement it's going to go in and out, right? So there is going to be a lot of brunt on your torp and port. So over years we had given a dissertation and almost 100% of the torp and port had come out. And that is the reason that people have stopped using less of the torp and port. Even when you have put this, right? So that is why the interposition of the cartilage is a must in case of a torp.
Another advantage of this interposition is the surface area. Okay, when you keep the graft, what she has already mentioned, the length is increases. Another is the surface area. So whatever the sound through the external auditory canal reaches onto the drum, that is transferred through the cartilage, more surface area of this whatever we have kept it up, and to the head, right? So it receives the sound's energy from broader area and it transmits to the lesser area. So more energy, sound energy passes to the inner ear. So that is the two main advantage when you put graft directly over the stapes, or you put something pork material and you keep the graft. So those are the two advantages.
What are the complications that are associated with the bladder? What possible complications you can encounter while doing modified hereditary? As you are going to do that,
Damage to the dura.
how will you know that you are approaching dura before during surgery? Dural damage will not suddenly occur. There is a sign that now the dura is going to come.
It can be a hue of reddish.
No, usually you will have some bleeding in that area, and it means that you are very near to the dura. So that can be dural injury. Then,
So we'll start
all
from
right.
zero. Like you started drilling, right? So you start drilling from where? Maximus, right? Okay. Then how much depth you go, you'll find the intrum?
1.5 centimeters.
Around 12 to 15. How will you know that this is antrum and not a corner septum or a false antrum?
In the floor of the antrum, I would, there is the presence of lateral semicircular.
Lateral semicircular, and then superiorly there will be, if you pass a flow, there will be editors and antrum, and if you drill a little bit, you will be able to see the short process of ingress. Okay. So you have entered the antrum now. How are you going to go ahead?
Suppose
एंट्रम आ गया उसके बाद क्या करोगे वाइडन okay how long will how much will widen
Will up to the tegment plate superiorly, posteriorly up to the sigmoid plate and inferiorly up to the digestive plate.
and as madam said how do you know that you reach the tegment plate and you are about to enter into the dura now
Then there is a bleeding.
yeah okay same for the sigmoid sinus how will you know that the sigmoid is going to come now bluish tinge will come right now what is the synodural angle in this case what do you mean by synodural angle you will reach into the synodural angle no? So how do you know that you have reached the synodural angle huh?
It is an angle between the dural plate and the synovial.
But how do you know that it is? There will be merging of the dura with the sigmoid sinus, right? So that is the synodural.
what is the importance of it? What is the importance of the Troutman's triangle?
What is the difference?
Posteriorly it is bounded by the sigmoid sinus, superiorly by the superior trapezius sinus and anteriorly by the medial and through which we can enter into the posterior.
Yes, very good. So the infection from the middle ear can go into the posterior fossa is one of the entry to it, and it is also an approach to the posterior fossa. One of the.
Then how will you go ahead again? You have reached the tegment, you have reached the dura, you have reached the synovial angle, the dome is right in front of you. Now what? You want to do you're planning for a gap or you're planning for MRI? You are doing MRI, right?
So the complications, if you go, first of all, you can have an injection facial nerve paralysis if you are doing under local anesthesia. Secondly, once you open it, you may have you may go into the false antrum. How will you know that this is antrum? She said that it is a facial short process. So you have an instrument in your tray that yes, but it is known as an antrum seeker. So it rotates 360 degree in the antrum, so you confirm it that it is an antrum.
What is the disadvantage of nowadays we don't have antrum seeker or market. Why not? What is the disadvantage of using an antrum seeker? Nowadays we don't use antrum seeker.
Yes.
Yeah. Because even we had learned we have never used antrum seeker. So why?
But that is theoretically.
Yeah, we should not use antrum seeker because you have to widen the epicus and antrum. You have to see the short process of the incus. You have to see the inculomellular joint, and then you have to find that it is going into the editors and antrum. Seeking the antrum using the antral seeker is a blind procedure, but that can lead to more vibration and thrust on the stapes and can lead to sensibility.
Yes, that may be their theory, but the instrument is that we are using in the mastoid. We are not using in the middle ear. It is just exploring only in the antrum, which is the big air cell. We are not going anywhere away from now. Can you tell me which are the other head cells? We'll go to it later on. But which are the other complications associated with it, with MRI? And we can go to the ossicles.
Your cortical mastectomy is completed. What are the boundaries of cortical mastectomy?
We are looking up to the segment with posteriorly up to the sigmoid sinus, inferiorly up to the digastric ridge, and anteriorly posterior
Canal wall.
and medially up to the lateral surface.
Posterior is SDM. Okay. And anterior superior? Fossa inferior, you should be able to see the incus, short process of the incus. And inguinal joint also. Okay. Now how will you go ahead? Cortical mastectomy हो गया.
Then by elevating the TN flap, I would like to.
So you want to elevate the TM flap after doing the cortical mastectomy?
Or before?
Initially, we check the ossicular status by elevating the TN flap.
Is it the ossicular status you want to check? That's why you do a Anybody?
Why you elevate TM flap first and then go for mastectomy?
Exit side of editors.
What?
No. TM flap, why TM flap you elevate first and then go for mastoid opening?
He wants to say something. Yeah.
By elevating the tympanomeatal flap, if there is a small retraction pocket, and we can know the extent of the pocket.
You want to confirm your diagnosis.
Yes.
Whether it is really a cholesteatoma or just a debris which you can just clean it up and then no need to do anything further.
Yes.
So you want to first find out whether there is real cholesteatoma or not, whether there is a real perforation or not, and by after elevating the flap, whether you can clear up that disease or not. If you can clear up matlab cholesteatoma, you have cleaned the whole thing, right? And then you will see the ossicular
Yes.
right? So you will first do the microscopic examination without elevating the tympanomeatal flap. However, you have done an otological examination, microscopic examination pre-operatively. On table you will do that, and then you will elevate the tympanomeatal flap. You will confirm everything, and then you will go in for a post-oral incision and then do the rest of the things, right? Okay. अभी क्या करोगे? You have one particular mastectomy. Now next. You have elevated the tympanomeatal flap, it is a cholesteatoma. You are not able to clear the disease by just sucking it out. You have to drill a lot of things and then you will be able to. How will you go about it? Then you will decide for a canal wall down or maybe canal wall up, we do not know, but in this case canal wall down. Okay, what will you do?
Not really the bony meatal, posterior bony meatal wall.
Start from the lateral most portion. Yeah.
What is the difference between breach and reach?
Which is the bone lying over the vertical segment of the facial
Up to?
Okay.
to the medial.
It starts from there and ends here.
First you tell breach, first you tell breach, then you will be able to answer reach.
Superior bony canal wall lying lateral to the ossicles and the horizontal.
Extending from where to where?
Anterior buttress to the posterior bony canal.
Covering up to editors, sort process. And reach is from the
Medial tympanic sulcus to
the
bony
up to
bony meatal bone.
up to mastoid T. Stylomastoid region actually.
Up to the mastoid tip. Occasionally you might have to drill it up. In that case, the stylomastoid.
Yes.
But the mastoid tip, right? That is the inferior most boundary. Superior most boundary will be the third process of incus. Medial most boundary will be the annulus. Lateral to the lateral to medial. That is the boundary. So we started drilling from up down. Yeah, down up. Up down. And lateral to medial. Medial. Lateral. Anterior to posterior, posterior. If at all you have to thin out sometimes, like if there's a lot of bony overhang in the retrotympanium, you might have to posterior, anterior to posterior. Mostly the facial now will be much posterior. So you will not drill posteriorly just like that. right? Okay, so we have drilled the bridge, you have drilled the ridge, and you already said that you will drill the lower the ridge up to the level of the facial, vertical segment of the facial canal, bony canal, right? How will you know that the bony canal has come? Facial has come?
Along with the nerve, there is the vessel.
There will be vessels, and before that, वो vessel कहीं से तो जा रहा है ना, so you will get a sometimes little bit bleeding here and there. And how do you know that? What is it called as? Thinning of the facial canal is called as. There's a word used for that. Yeah. It's called as eggshell thinning of the facial canal. It's like the egg, मतलब egg like टक करते हैं तो टूट जाता है ना, उतना thin हो जाए, it will be so transparent that you will be able to see the facial vessels going on, facial teeth आपको दिखेगा, but still howsoever thin you have done, there will be a thin layer of a bone on that. So that is what is called as the eggshell thinning of the facial canal. Okay, so you have drilled up the facial canal, you have removed the facial bridge, right? Now what will you do? अभी क्या करोगे?
From the hidden area.
But when you are drilling the bridge, removing the bridge and the ridge, if the IS joint is intact, are you supposed to do something? Is there any chances of you hitting the incus and hitting the loss secondary to vibration of the drill?
So you will dislocate the iliopsoas.
See, that there is a reason that you have to examine the ossicles. If there is intact ossicles, if you are going to drill, you have to first dislocate the IS joint and then you drill so that you will not transmit your vibration into the inner ear and it will lead to sensory level. Okay.
What are the types of mastoid hair cells?
Intro, the largest cells in periintral cells, perifacial, sinus, perisinus, retrofacial, tip cells, zygomatic cells, peritubal cells, keraticochlear cells, pericardiac cells, vitreous, supralateral.
What are the common areas of residual disease?
Retrofacial and pericardiac.
Then?
Facial disease and sinus dependent.
Then?
What is sinus tympani?
Sinus tympani is bounded superiorly by the ponticulus, inferiorly by the subaqueous, and laterally by the vertical ridge, facial ridge, and medially by the pronotum, and posteriorly by the posterior sinus.
Yes. How to examine the sinus tympani?
What was
Nowadays
upon the depth of the sinus tympani.
If you don't have, in previous era, you had no endoscopes available, especially the angulated one. There is some mirror. No, mirror. Chinese mirror. Yes.
Or smaller size of PRS mirror you can just put on the promoter.
Yes, and reflect. Yeah.
Yes.
But nowadays you have endoscope, you have a clicker endoscope, so they don't need that.
Yes.
Historical reference, no.
What are the causes of post-operative discharge in cavity? Last question.
Secondary infection.
Common causes of discharging middle ear, operative
Post-operative.
One is maybe secondary infection.
Non-ideal.
Non-ideal.
ये दो क्या points हैं?
What are the points?
Very high ridge.
Yes, very good.
High facial ridge.
Incomplete canal wall down.
Inadequate, yes.
Inadequate removal. Yes.
Then
Residual disease.
Residual disease.
then meatoplasty.
Narrow
Inadequate, yes. Inadequate meatoplasty.
And saucerized, round head.
Proper socialization.
So this was second last question. Last question is what are the 4Ds in operated cavity that led lot of surgeons to do canal wall up surgeries in comparison to down?
Dependency, dissolvability, deafness,
And discharge. Done. Good presentation. Vote of
How did you all find this? Hello? कैसा लगा? What doing or not working? We should have more of this.
આપણે તો એક્ઝામ માં ગયા એટલે
Anyway, at the outset, I thank all the participants without whose help this would not have been possible. And this has become possible because of all interaction from all of you and all the faculties, all my colleagues. And look forward that we'll have more of this kind of a teaching sessions. The exams are coming up very shortly, and if anybody is interested, I am available 24/7 तो नहीं कहूँगी, but morning 8 to night 10 p.m. You can contact me anytime. I am ready to spend maybe 2 hours, 3 hours on Saturday, Sunday. We can sit together and discuss. Even most of the faculty also will agree if they want to join us. Right?
Any question from you guys? That would be the last question.
Any question?
કોઈ ક્વેશ્ચન નથી એના મતલબ તમને બધું આવડી ગયું
जो भी क्वेश्चन पूछे और जो भी आंसर हमने भी नहीं दिया, आपने भी किया, ऐसा कुछ रह गया, something to read for us. Okay, so all questions are answered, right? And thank you, Bharat Sriram, Pankaj Bhai, for putting this up. It was a great show, and looking forward that you will help us and support us in future. Thank you.